just get a thumbs up or something in the chat just to let me know that you can hear me and see my slides. Okay, so are you guys able to hear me? Okay, great. Perfect, perfect. Um, Welcome to our clinical consultation webinar. As I'm sure I may have seen a fair few of you around in the past and in the previous webinars. My name is Shoaib and I'm the course organizer for BitePACES. And before I hand over to Samra, who's kindly going to be doing our webinar this evening, just a quick run through the course as usual. So as you guys may well know now, we have courses coming up pretty soon in September and October. We have a 1 day and a 4 day course, and we're going to finalize the patient list very soon, and we have some exciting cases lined up. So please do join us. We try and get through as many great cases as possible. We've trained several hundred doctors over the last year with hugely positive feedback. So please do join our course. And if you don't want to join our course, that's fine. We still have our free webinar series. Please join our WhatsApp group. The QR code is there. You can find out more about upcoming webinars. Next one is on Wednesday on neurology. So I know that's quite a popular one. And top right corner is a QR code to www.bitepaces.com where you can sign up to our courses. And we have a discount code, webinar20, which will get you some money off the tickets. Um, Here's some feedback from previous courses, and we tend to get a lot of positive feedback. One person here saying that she passed with 100%. Plenty of feedback there on Google, which you can work your way through if you're interested. But yes, please do join us. Courses coming up in the next month. And next webinar series is on Wednesday covering neurology, because that was by far the most popular topic that you guys wanted us to cover on the WhatsApp group. And I don't want to bore you too much with that information. What I'm going to do now is I'm going to pass over to Samra, who's going to run through a few clinical consultation bits and pieces. So Samra, whenever you're ready, you can start sharing your screen. Brilliant.
Hi everyone. I'm not sure if you can see my screen, and are you able to hear me?
Yeah, I can see the screen and hear you. Thanks, Samra.
Okay, perfect. So my name's Samra. I'm one of the immunology and allergy and immunology registrars in Oxford. I sat my paces last November, so I was one of the first sittings with the new format, and I will run through the part 2 of clinical consultations. I think Vishnu ran you through the first. So just a quick overview. What we'll cover today. So we'll just quickly go over the new PACES format and then go down the breakdown of station 2 and 5, which are the consultation stations. I'll quickly run through mark schemes and how to present your findings, and then we'll practice a few consultation stations. So in terms of the format, the new PACES have taken out the history station, and we now have 2 consultation stations. So instead of 1 station 5, we have 2 separate consultation stations, and I'll run through that in the next slide. So station 2 and 5 form the clinical consultation station. So we have 15 minutes to examine, take a history, answer patient questions, and then we have a 5-minute Viva at the end. In terms of the consultation stations, you normally have 5 minutes reading times before the station, where you'll be given a small brief. It might be a GP referral letter with some basic investigations. That's the best time to sort of sit down, jot down your ideas, possible diagnoses, before you go into the station. And then you have 15 minutes to get to your diagnosis and then answer patient questions, examine questions. So in terms of the mark scheme, the consultation station actually examines and marks all your 7 domains. So from physical examination to communication diagnosis, and also welfare. And you'll have two examiners marking you on the station. So, like I was saying earlier, in terms of station breakdown, you have 5 minutes time to prep, which is what I did was sit down, read the scenario carefully, and then jot down all the possible differentials. Um, oh, someone's raised their hand. You can, if you can unmute yourself, I'm happy to answer any questions that you have. Okay, I'll just carry on and then we'll take questions at the end. So, and then you have 15 minutes for the actual station. It's important to make sure whenever you enter the station, clean your hands, introduce yourself, and then take a focused history, depending on what your scenario is, and make sure that you always ice at the end. So, patients' ideas, concerns, expectations. From your history, you then want to do a focus examination, and after that, sit down with the patient again, explain your likely diagnosis, and answer any questions. It's a really good practice to then sort of revisit ICE and try to address the concerns that they raised earlier and also ask about any new questions they might have. You will then have a 5 minute viva um, where your examiners will ask you your diagnosis, further investigations and management, and then ask you some questions about the actual case. So I use this format in my PACES exam for all my stations in terms of how I presented. So I would start off with the most likely differential is, and then support that with my positive findings and any important negatives. You also can mention the complications or severity from that sort of diagnosis and what the most likely etiology is. So, for example, if you had a renal case, you could say the most likely differential is a functional renal transplant, as evidenced by a sort of J-shaped scar with a palpable mass. And you could talk about important positives also including any dialysis lines, any fistulas, if they have a thrill, or if there's any signs of recent needling. In terms of complication and severity, you would look for any signs of overload and any signs of sort of side effects or complications from immunosuppressive medication. It's really important to look for any sort of signs of etiology and mention that in your presentation as well. So, for example, if it's a diabetic cause, then you can mention there's signs of sort of finger pick needle scars. It's really important to include other diagnoses as well and what you would do to investigate further. So I'll just start off with some cases. So one of the first cases that's similar to what I had in my exam was a 78-year-old lady who was referred to you by her GP with a history of collapse. And the referral letter will look something like this. So you get a letter from a GP with some basic investigations. So what I would do in the first 5 minutes that you have as a brief when you're sitting outside before the station starts is read the referral carefully and make sure that you look at the observations in detail and then formulate possible diagnoses that could be causing a collapse. So I would sort of break it down. You'll have a pen and paper to jot down your diagnoses, and sort of you can take that into the actual exam room to work through if you need. So I sort of put collapse into syncope and seizure with possible causes including toxins, drugs, and also any sort of postural symptoms or cardiogenic syncope. And then I would work through those diagnoses and make sure I use those focused questions in my history taking. So I'll just go through the history and what I did. So I asked them about the onset, which she mentioned was sudden onset whilst driving, and how long it lasted. She mentioned it was a few seconds. She came back round straight away. There was no signs of any post-ictal phase, and she didn't have any sort of postural symptoms or any prodromal symptoms at all. She didn't have any significant trauma from her collapse whilst driving, and However, the important thing that she did mention was that she has noticed reduced exercise tolerance due to worsening shortness of breath on exertion. I did ask about any previous history of collapses, which she said she did have one history, which she didn't see the doctor for, and so it was not investigated. And then sort of run through past medical history again, ask about any sudden cardiac death or any cardiac history in the family, any medication that she's using. It's important to ask if she's taken anything over the counter, if she's had any recent illnesses or taken any antibiotics. Um, Again, make sure you ask about alcohol and smoking. And this brief did mention that she was driving, but sometimes you might have a brief of collapse, and it's important to get the history if they are driving, because then you'll need to give management advice based on that as well. And I did ice, and she mentioned that she was concerned about a future collapse and possibly having severe consequences from a crash. So on examination, so she had no peripheral stigmata of any cardiorespiratory disease. She did have an ejection systolic murmur that radiated to her carotids, and I did note that she had a slow rising pulse. Um, on examining her chest, I found that she had bibasal crackles and some fluid in her lower legs. So I then went back to the patient and sort of explained my findings to her, and most likely diagnosed that this was a cardiogenic cause, and most likely a valvular pathology. Explained that we will further investigate this with sort of further blood test and then an ECG, and we will get a scan of the heart as well as a 24-hour tape. It's important to sort of familiarize yourself with the DVLA guidelines. I told her not to drive for a duration until she was seen by cardiology, and that she would be referred over to them. In terms of the Viva, the so I similar to the format I suggested earlier, I explained presented in a similar format to explain that the most likely differential was of cardiogenic syncope from valvular pathology. This was evidenced by sudden loss of consciousness with no prodromal symptoms and no post-ictal phase. She had a slow rising pulse and ejection systolic murmur radiating to carotids on examination, and there were signs of cardiac dysfunction, including pedal edema and bibasal crepitations. My other differentials would include cardiogenic syncope from other arrhythmogenic causes such as long QT and heart block. Other differentials would also include vasovagal and orthostatic hypotension. To investigate further, I would get a Langham standard blood pressure, an ECG, bloods, 48-hour tape, echo, refer to cardiology, and advise not to drive until seen by cardio. So in terms of questions that you could get in the case, one includes, what other device could you use to investigate cause of collapse in this patient? So another device you could mention was a loop recorder. They do ask you about DVLA guidelines, so I would suggest going to DVLA guidelines on the government website and sort of familiarising yourself with sort of heart, as well as seizures and sort of hypoglycemia in diabetic patients. So I advise that the patient should not drive for 6 months, and this will be 12 months in someone who drives a bus or lorry. And again, they can ask you about drugs that can cause arrhythmia in patients. So this is just a screenshot that I had from the DVLA guidelines. So they have lots of different guidelines regarding what type of syncope a patient has. So mine was unexplained syncope, and you can say it says 6 months in group 1 and 12 months for people in group 2 vehicles. But yeah, make sure you have a look at the DVLA guidelines and memorize the common ones. So like I said, diabetes, cardiogenic cause of syncope, seizures. Okay, so just moving over to case 2. This was a 62-year-old lady who has been referred to you by her GP with a history of painful hands. So similar, you will get a referral, and you will get some basic investigations such as some blood results and observations. And like I mentioned earlier, I did a 5-minute prep. I went down on possible causes of painful hands and wrote them down on my sort of notes outside. So again, you can divide it into smaller things. So Raynaud's, is it primary? Is it related to another inflammatory condition? Carpal tunnel, is that due to an endocrine or metabolic cause? Has the patient had any trauma or repetitive strain injury from occupation? Are there any inflammatory causes such as rheumatoid or Jacques? Or is this all just wear and tear on osteo? So if you go back, the age of the patient was important. She's 62, and then sort of getting more, and she's got a CRP of 15. So going down the history, so it's important to get the timing. If this was sudden onset pain in her hands while she was doing something, or if this is gradual onset over a few weeks or months. So she reports that she's had it for a few months, 2 years. Both hands and feet were affected. She has early morning stiffness, or over an hour in the morning, and has had episodes of red hot joints in the last few days, in the last few months, which last a few days. Ask about any exacerbating or relieving factors. So is this made worse in cold, which suggests more Raynaud's, and if she's had any, if this has affected her function at all. When you're thinking about inflammatory arthropathies, it's important to ask questions about any extra articular features. So make sure that you ask about if you're querying sort of psoriatic or rheumatoid, ask about any back pain, if she's had any skin changes, any sort of painful dry red eyes, or if she's noted any neck pain at all. And think about other sort of extra articular features where inflammatory conditions can affect. So inflammatory conditions mostly do affect the lungs. So ask about shortness of breath, and then sort of more systemic sclerosis symptoms would be sort of the GI symptoms as well. Ask about their past medical history and any family history of any autoinflammatory diseases. Again, it's important to make sure you ask about over-the-counter meds and ask about how much they've been using. So she's mentioned that she's had sort of severe pain for a few months. Has she used anything for it, and has that helped at all? And as I mentioned, she's got worsening dexterity and function, so it's important to ask about her occupation and how this is affecting her occupation. So she works as a cleaner, meaning she uses her hands really frequently. How is this affecting her? And ice again. So on examination, so it's important to have appropriate exposure, ideally shoulder down. Make sure you're examining her from afar, and then sort of get closely to sort of examining close from elbow down. You're looking for any scars, any rashes, importantly, any psoriatic plaques. Look for the nails for any changes and the muscles for any signs of wastage. Do the hands show any obvious signs of deformities? And is there any active signs of inflammation at the moment, such as red hot joints? After you have sort of spent time examining, you want to feel, is there any signs of any acute hot joints? How does the pulse feel? And then you want to examine all the smaller joints and see if there's any signs of any swelling or pain. You also want to examine the elbows. Again, you want to look for any signs of any nodules or any tenderness or bursitis. So this patient, as you can see, she had bilateral deformities in her small joints, as well as some nodules. Once you've assessed by feeling, you want to go to sort of checking the function of the hands. So is the patient able to actively perform tasks? So you want to get them to actively move, including straightening the fingers, forming a fist, wrist flexion, extension, and then do those movements passively. A big differentiation would be patients with Jacques would struggle to fully straighten fingers and form a fist, but when you do that passively, they should be able to do it. So that would help sort of differentiate between two different conditions, which sort of Jacques looks similar to rheumatoid. And then you want to check their function. So check their pincer grip. Are they able to tie the shoelaces, button up? And you can also do special tests such as carpal tunnel if indicated. Once you've examined the hands, it's important to examine the patient as a whole. So look for any extra articular features, look for any eyes. So rheumatoid can cause anemia. Look for any signs of any conjunctival redness, which suggests more sort of any other autoimmune disease. Look for any signs of any rash. What people miss frequently is looking behind the ears, where there might be any signs of small sort of spheritic plaques, if the disease is well controlled. So make sure you look at the ears and scalp as well. Rheumatoid often affects your neck, so check if they're able to flex and extend their neck. Listen for heart sounds. Is there any signs of any pericardial rub? And like I said, inflammatory diseases affect the lungs, so look for any signs of crepitations. This patient had fine end inspiratory crackles, which persisted on coughing. Abdomen, is there any signs of organomegaly? And again, look for any rashes or ulcers, which might suggest pyoderma gangrenosum or any vasculitic rashes. Now that you've noted that the patient has got a bilateral small joint arthropathy, you also want to have a look at the feet to see if those have been affected and if the function has been impaired from that. So in terms of patient discussion, so you would go back to the patient and explain that the sort of information they've given to you and the examination suggests that they likely have an inflammatory arthritis. Explain their further investigations and management, so what you do going forward, and address any concerns. So this patient asked, why are my hands painful? And explain that it's due to an inflammatory process, which is causing sort of cells, within their own immune cells attacking the joints, and that's causing the pain. But we will start on appropriate therapy and appropriate analgesia to help with that. If the patient asks about will my hands go back to normal, you have to be honest and it's advice that the damage that has been done to the joints unfortunately cannot be reversed, but we can prevent further damage, and we will give you we will refer you to rheumatology, who will start you medication that will help prevent that further damage going forward. We can also give you a letter for work and ask them to accommodate you. So again, in terms of the viva and presenting back, going through the similar format. So the most likely differential is that of seropositive rheumatoid arthritis. This is evidenced by a symmetrical deforming small joint polyarthropathy with small muscle wasting and distal interpharyngeal joint sparing. There was active synovitis at the MCP joints and nodules were present. Her hand function was restricted by deformity and weakness. Important negatives include no skin rashes or plaques, no nail deformities, and no GI symptoms. She did have evidence of respiratory involvement with bilateral fine end inspiratory crackles, and she reported worsening shortness of breath. This could suggest ILD secondary to an inflammatory arthritis. There was no signs of splenomegaly or signs of carpal tunnel. Other differentials in this presentation would include psoriatic arthritis and Jacques arthropathy seen in lupus. So in terms of investigating, I would like to get bedside saturations and do a full blood count to look for any signs of anemia. I would do a white cell count to look for raised in white cells. A raised CRP and ESR would suggest inflammation. I would also like to look at her renal function and LFTs, which can be impaired. And then you would like to do some serology and check the diabetes and cholesterol. So I'm doing an ABG and chest X-ray because of her respiratory symptoms. And you would get joint X-rays as well. In terms of analgesia, so you will start with simple analgesia, so paracetamol, codeine, COX-2 inhibitors. You could consider steroids if they have signs of any active disease, but normally you would leave that for the specialist, such as rheumatologists, to start. So you refer to rheumatology, who would then commence on DMARDs once diagnosis is confirmed. You would also refer to respiratory given her lung findings, who could perform an HRCT and lung function tests. Given the significant impact a condition has on her work, you'd want to refer her to occupational therapy and physiotherapy and provide her with a letter for works so that they can accommodate changes for her. In terms of possible questions that you could have are what would the X-ray changes be? So just familiarize yourself with possible X-ray changes with patients that have inflammatory arthritis and how that would differ from people that have osteo. And what would the management be once a rheumatoid arthritis is confirmed? So remember, it's an MDT approach. You want to educate the patient, but you want to get lots of different professionals involved, including pharmacists, orthotics, nurses, podiatry, into respiratory, and that you want to manage the patient's symptoms. So pain is a big issue there. You want to make sure that she has appropriate analgesia, but also we want to manage her symptoms of joint pain, what is causing that. So acutely for flares, you'd manage with steroids, but long term, you'd want DMARDs or biologics. You also want to provide secondary prevention, so look for any signs of, so give bone protection and monitor for signs of osteoporosis. And in the future, the patient might be a candidate for surgical intervention. So the last case I have is a 24-year-old lady that was referred by her GP due to palpitations. So this is the referral by her GP. And like I said, I'll spend 5 minutes going through the referral, reading it properly, and jotting down my possible differentials. So with hers, her doctor mentions that her full blood count and kidney function are normal. So common cause of palpitations would be anemia or hyperthyroidism, but you can see that both of those have been ruled out by her GP with a normal full blood count and kidney function. You can also see that her GP did some observations and her blood pressure was high. That could suggest it might be anxiety related if she is anxious in hospital with his white coat, or there might be another endocrine cause causing the high blood pressure. So again, 5 minutes before the station, you want to jot down any possible differentials that you can get from that history or brief. So like I mentioned, endocrine causes like hyperthyroidism, low BMs, any electrolyte disturbances. If this is anxiety related, she is a lady in her 20s. Could this be pregnancy or PE if she's using contraceptives? Could this be a cardiovascular cause? Has she had any recent changes to medication, or is her lifestyle causing these symptoms? So in terms of the station, so you ask about what does she mean by palpitations. So she mentions that she feels her heart is racing and occasionally skipping a beat. How long has she had this for? So she's had worsening palpitations for the last week, but she has had them intermittently for 3 to 4 months. Do they come on after any event? Does anything cause it? Any posture? Is this associated with activity? And she mentioned that no, they're all just start suddenly with no precipitating cause. She isn't able to stop the palpitations by Valsalva or any other maneuvers, and has had no syncopal or presyncopal symptoms with it. She does feel sweaty and occasionally does get chest pain, sometimes nausea and vomiting, and feels hot and flushed. You want to ask about any weight loss, if her periods are regular, have they got heavier, suggesting that she become more anemic, lighter, is she hyperthyroid? Again, that would also be a good factor to sort of figure out when was her last period. Is there any possibility that she may be pregnant? Has she had any symptoms with, again, hypothyroidism? Has she had any signs of exophthalmos or any neck pain, suggesting any goiter or swelling there? Has she recently had a viral infection that would have precipitated more palpitations recently? What is her lifestyle like? Is she sleeping well? Is she having lots of caffeine, alcohol? Has she had any recent life events? Has she had any recent travel? So as you go down the history, you want to sort of tick away the possible diagnoses that you have. In terms of a past medical history, it's important. Again, she's got palpitations, and her OBS suggests that she has a high blood pressure. Does she have any cardiac disease, any autoimmune disease in the family? Is she taking any medication, anything over the counter? She's a final year nursing student, so is she increasingly anxious? Is she sitting any exams? Has she got any deadlines coming up? And ice again. So this patient was really scared. She was terrified and thought she will die. Again, you want to then do a focus examination. So from that history, you will have come narrowed down to possible diagnoses. So mine would have been a possible hypothyroidism, and has she got any other underlying disease like FIO? So you start off from general inspection. She looks a normal weight. There's no signs of any hair loss, and she's not increasingly agitated or restless. I couldn't see a tremor. Um, you want to take a pulse, and she was tachycardic. And then you start off examining. A focused thyroid exam is what I did. So I looked at her eyes. Was there any signs of exophthalmos, any periorbital swelling, or any signs of anemia? And then I went to examine her neck. There was no goiter, no scars, and no retrosternal dullness, and she had normal swallow with a normal voice. You ask her to stand up from a sitting. She had no signs of proximal myopathy, and then assess her reflexes. And since all of that was normal, I wanted to examine, sort of listen to her heart, make sure the heart sounds were normal, and that she had a normal JVP, and then examine her abdomen to see if there was any signs or anything suggestive there. So essentially, examination was normal apart from tachycardia that I could find. So the tachycardia plus a high blood pressure in observation could suggest a possible underlying cause for a symptom, which might be from endocrine cause, and that we want to investigate this further. So we want to look into doing some more blood tests and possible more imaging to figure out what's causing these symptoms. Again, I use a similar format for presentation. So the most likely differential is that of a possible pheochromocytoma. This is evidenced by severe hypertension, the classic triad of headache, sweating, and palpitations. There was no signs of any thyroid mass, goiter, or any signs of thyroid disease. Other differentials would include hypothyroidism, primary hyperaldosteronism, and anxiety. So to investigate further, you want to repeat the blood pressure and get a pregnancy test and urine dip. You want to do some bloods and urinary metanephrines, and then you can do some more specialized tests to look into FIO. So possible questions that you could be asked is, what is the management if this is a confirmed pheochromocytoma? So you want to sort of divide that into pre-op, surgical, post-op, and long-term, and mention about monitoring for any signs of recurrence. Going forward with that, what is the prognosis if so normally it has a good prognosis if it's diagnosed early with when the patient doesn't have any hypertensive crisis. However, when patient does have signs of hypertensive crisis or complications suggesting heart failure, then that can impact long-term health. However, most patients do improve once they've undergone surgery. I would suggest reading up on FIO and looking through sort of genetic associations with other conditions, and having some that you could sort of, you can throw off your tongue once they ask you about any associated genetic conditions. So MEN2 and von Hippel-Lindau are two. So in terms of your Viva, always have three differentials at the tip of the tongue for everything. So for example, if there's hepatomegaly, just have three diagnoses for everything. Make sure that you answer the questions directly and succinctly. And that's the end. So BitePACES are running their course. They've got some tickets available in September and some available in October as well. And they've got a 4-day course in that also has limited tickets available. They do have a discount code, webinar20, which gives you 20% off from the course. I'm just going to go through your chat and see if you have any questions. More than happy to take any questions if you have any, but I can't see anything at the moment.
Thanks so much, Samra. That was fantastic. Let me just see if you have any. Can't see any questions, but if anyone does have any questions, then please do pop them in the chat. And Samra's also, she's one of our faculty. She's also on the WhatsApp group. So if you have any questions for her, just you can always drop us a message and one of us can try and get to it. Okay, I don't think there's any questions coming through, Samra. So that's fantastic. Thanks so much for delivering the webinar. I hope you guys found it useful and please, as I said, please send any of your questions through to the WhatsApp group if you do have any. Check out our upcoming courses and our next webinars on Wednesday. But till then, I hope everyone has a lovely evening and we'll see you in a couple of days. Thanks a lot, Samra.
No problem. Thank you. Bye.
Take care. Bye bye. Bye, everyone.